Yeah, please start.
Good morning. I'm VIVEK ARAVIND. My topic for today is efficacy of INTRASTROMAL VORICONAZOLE injection as an adjunct in non-responding fungal keratitis. Fungal keratitis is a serious cause of blindness worldwide. It accounts for 30 to 40% of the keratitis in some part of the world. In India, it's more than 50%, and it's more common in tropical and subtropical areas. Treating fungal keratitis is a challenge for ophthalmologists as the penetration of antifungal drugs are inadequate. Voriconazole is a triazole antifungal agent and is a has a broad spectrum of action. The economical and efficient strategy of using voriconazole is through intrastromal route. In our study, we have reported the use of intrastromal voriconazole in 84 patients who are not responding to topical and systemic antifungal drugs. The aim of our study was to study the efficacy of intrastromal voriconazole injection as an adjunct in non-responding fungal keratitis. The objective was to compare the pre and post treatment size, depth, and infiltrates best corrected visual acuity over a follow-up period of 1 month, and to observe if for any complications, and to study for the association of risk factors like topical steroids and uncontrolled diabetes. It was a hospital-based interventional clinical study. The clinical data collection were undertaken following an ethical and written informed consent. All patients underwent a detailed examination. The study duration was 18 months. All patients with fungal keratitis proven by the presence of fungal filaments on smear or culture and not responding to topical natamycin and oral itraconazole for 2 weeks were included. And the patient with adjacent scleral involvement, impending or frank corneal perforations, presence of desmetocele, endophthalmitis excluded. Then the method of intrastromal injection preparation: 2 milligram of dry lyophilized powder will be reconstituted with 4 ml ringal lactate solution to form a concentration of 500 micrograms per ml. The reconstituted solution will be loaded in a 1 ml tuberculin syringe with a 30 gauge needle. Under topical anesthesia or peripulvar anesthesia, the preloaded voriconazole will be injected into the cornea under operating microscope, and the needle will be entered from a clear zone till the margin of the infiltrate at mid-stromal level, and the medication will be given at 3 to 5 divided dose around the infiltrate. Then coming to observation and result, higher number of cases were seen between the age of 46 and 60. And most of the patients were from rural areas, and 50% of the patient had an agricultural background, and most of the patient had a history of injury, and the most offending agent for the trauma is vegetative matter. Then 13% of the patient had uncontrolled diabetes, 6% had topical steroid usage, and 4% had dacrocystitis. The time of presentation was 16 to 20 days of onset in most of the cases. Then scar formation was started in 47 patients by 7 days, and 54 patients got improved in 21 days, and 22 patients had to undergo intervention like therapeutic penetrating keratoplasty. Then best corrected visual acuity also improved in 50% of cases after injection. Then coming to discussion, our study had higher number of sample size when compared to similar studies, and 73% of the patient got improved in our study. Then in conclusion, it can be used as an adjunct. Epithelial defect size and stromal infiltrate size has a correlation with the efficacy, and it is also cost effective, and intrastromal injection of voriconazole is safe. In our study we didn't come across any complications. The limitation of our studies, we did not take any control group in our study, and the follow-up period was only of 1 month, and the causative organism might be having an impact on final outcome. Thank you.
Thank you so much. It was a nice presentation. Dr. Jyoti, your comments, please.
The treatment of intrastromal voriconazole is already published about 11 years ago. So anything innovative that you all did in this particular study?
No, actually, ma'am, the positive side of our studies, we have a larger number of sample size. Most of the studies had only 20 around sample size. So
ideally, what could have happened? You could have compared with different types of fungi and seen whether it really works.
yes, ma'am. That's our.
With diabetes, steroid. So your would have got more weightage to what you're doing, because what you mentioned is already reported. I understand number of cases, but doing something different would have helped in giving us more
Yes, ma'am.
information.
Thank you.